okay? Maybe that's why nobody references me on immediate load.
Fixed ones.
Fixed. I would put it with temporary cement, yeah. Yeah, and then, what was the question? I'm losing it now.
The breakthrough on the blade implant.
Oh, yeah, good, yeah. So now, all of a sudden, over the years, I started getting failures. So I started opening up the tissue to see what's going on. And I saw I was perforating through the labial concavities in the bone and the lingual concavities. I said, holy Jesus, the soft tissue, as much as I thought I knew something, especially in the maxilla, it completely camouflaged the underlying bone. I mean, I'd check the maxilla, especially in the tuberosity, as much as 18 millimeters across, buccolingually, covering a knife-edge ridge of bone maybe 2 or 3 millimeters. So I was perforating through everything. So at that time, I said, something has to be changed. Something has to be changed where it could go into these knife-edge ridges, these shallow ridges, these obliquely flaring ridges, especially like you have in a maxilla, and something has to be created in this implant that'll have necks coming down, supporting posts that could be bent so that they will be parallel with each other. Therefore, something had to be created that would use for the first time ever the horizontal dimension instead of the vertical dimension. And that was the birth of the blade.
So you continue to use the subperiosteal, throughout.
Absolutely.
So basically, when you were getting into larger heights, that's when you were looking for options outside the subperiosteal, correct?
Oh, yeah. When there was enough bone height, I used either blades or screws.
This is back in the 60s?
Yes, of course.
So, okay, so let me ask you this. When you look back retrospectively on your life, what, I think a lot of practical knowledge comes about through retrospective thought. If you look back retrospectively, what is something that you wish that maybe you had not done?
I guess I would have been more not the word careful, I'm thinking of another word, more when you choose your cases more than I did. In other words, I tried to play God on too many cases because I was out there to prove that implantology one day would be a great discipline. And there were times when I pushed the envelope too far, where I had failures because I just went too far, and I maybe my ego and my but more so than my ego and my desire to help these cripples compelled me to go on.
Okay, so and that's probably not a bad thing for all of us to be thinking about.
What kind of bone grafting techniques were available at that time?
I'll tell you what I did. I used to use, believe it or not so much bone grafting, but I used to use a lot of steroplaster of Paris. It was a great thing. I would take just plain fast-setting plaster, put it in a dry heat sterilizer, and mix it to a sour cream consistency, and put it right over the sockets, the open sockets, over the channels for the blades and everything else, and then suture up.
Yeah, and it would turn over too.
What's that?
It would turn over, calcium phosphate.
Very, very nice. It worked out very nice.
That was used for a long time, actually.
Yeah, very nice.
Actually, that probably was the first augmentation procedure.
Yeah, well, there's something even before that. What happened? Squib. I had a research product with Squib with about 5 other guys. I think they gave me $500. They had these strips of bone, bovine bone. It was about this size, like that, and about that thin, light as a feather. It was all of the ingredients were taken out of it. You know what I mean? And I used either 27 or 37 cases. I can't remember. I did that many cases.
When was this?
This had to be in the 50s. Yeah, in the middle 50s. Yeah.
Wow.
And I have all the cases on this. I got slides on all this. And every one I showed failed miserably. Okay? And I wrote to them and said this. But evidently, I was the only honest one. Because all the other ones evidently had great things to say because they put it out on the market. But 6 months later, it was gone. It was off the market. But, a lot of people, when they get a few bucks from these companies.
Eager to please
They're
the
eager to
manufacturer.
please, exactly
Yeah.
right. But I was
The
honest the
emperor's
whole
clothes.
way.
It's happening today.
It's happening today.
Yeah,
What sinuses? When did you start augmenting sinuses?
I didn't do that many augmentations of sinus. I first saw Hill Tatum do it, and I hadn't done it before that. In fact, what I was doing, Carl Misch even mentioned it in his lectures and in one of his books, that Linkow was the very first one to show that a blunted-ended blade can lift up
the
the Schneiderian membrane.
Yeah.
And that's how I used to do it. With if it was very low and it was a U-shaped antrum like this, then I would go ahead and blunt end the end of the blade and just
Knock it
gently
up.
break through the bone beneath
Three-stick
it
fracture.
and lift it up like that, you see, and get it
What would
in.
you put inside?
What I had then, at that time, we had this, I used to use calcitite, non-resorbable bone, and I used to use osteogen, and there was another one at that time, one of the earliest bones. I don't remember what it was. I would mix them up. And then I created I showed that too in the history, my basket blades. I had a blade implant with a basket. Some of them were movable and would go right on up. I'd fill it up with bone, okay? And again, you have to have a sinus like this because the blade was designed like this.
Right.
So what I would do, on both sides, mesial and distal to the sinus, I'd make my channels. And then I would make it wider, the bone, where the open sinus is, make it wider buccopalatally, all right? Then I'd fill the basket up with bone. Then I'd tap the blades in on both sides and then screw the basket, push it up.
Wow, incredible.
And I would reverse the Schneiderian membrane. So you'd see, after I'm done, you'd see bone like this
On both sides.
instead of like this.
Well,
How about success rates? What would you say your success rates were on subs and blades? And if you look,
In the beginning, in fact, I did it. In the beginning, my success rates with subperiosteal were kind of low, probably about 60% success.
At what-
because
how-
I did a lot of, I'll tell you why, because I did a lot of maxillary subs, and I did not know the
Kiss of
design.
death
I
there.
did not know the various densities of the bone. It didn't take me until years later to realize how bone resorbs, you see, all at the expense of the buccal-labial cortex going in obliquely off a horizontal plane. The palatal side remains solid and strong as can be. The anterior part remains solid. The anterior nasal spine remains solid. And so my subperiosteals over the years then were based mostly on the palatal side of the crest, where I make a big, broad palatal strap which resisted the anterior and lateral thrust of the tongue. And I went over the anterior nasal spine and just put 2 posts down here and try to stay as far away here, because this is where you got most of your failures, right here.
yeah, but they would settle up front and then pull out of the back.
Yeah, yeah.
Exactly. And then,
The blades, I had a tremendous success. What I had, I did, now this is, you may call it a peculiar way of judging what it is, but I had in my main operatory, I had a wooden frame with wooden slots. And it said blade, implants inserted, implants removed.
right.
So the girls used to change it every day. If I put 5 blades in or 5 screws, it would go up there. And if I took 3 out that day, that's how it would be. And when I quit, I had over 19,000 insertions with a little over 1,900 that I had removed. Now, that has not to do, but that had nothing to do with patients who left me and moved away, and they may have had them pulled out over there too. Who knows? You know what I mean?